Good. All right. So hello, I'm Lindsay at the Longmeadow Adult Center. Thank you for being here virtually or in person. Today, I am thrilled to introduce you to Dr. Budson, educated at Haverford College and Harvard Medical School. Dr. Budson is Chief of Cognitive and Behavioral Neurology at the Veterans Affairs Boston Healthcare System, Director of Education at the Boston University Alzheimer's Disease Center, Professor of Neurology at Boston University School of Medicine, and lecturer in neurology at Harvard Medical School. Dr. Budson is author of 7 Steps to Managing Your Memory, What's Normal, What's Not, and What to Do About It, along with 6 Steps to Managing Alzheimer's Disease and Dementia, a guide for families. We will be meeting you during the presentation, but please consider leaving your video on so that Dr. Budson can speak to an audience of faces. Feel free to use the chat during the presentation. We will have time for questions at the end. We will be recording today's presentation for those who miss it, and for Valley Eye Radio, which broadcasts local news and information to those who are blind, visually impaired, and disabled listeners throughout Hamden, Hampshire, and Franklin counties. And now I will turn it over to you, Dr. Budson. Thank you.
Well, thank you very much, Lindsay, for that very nice introduction. So I will be telling you today about all sorts of different things related to your memory. And I'll do this in a couple different ways. I'm going to show some slides. I'll sometimes be just talking to you just like this. And at other times, I will be reading a little bit from one of my books. And I'm going to begin by, excuse me, sharing a couple of slides here. So you should all be able to see my title slide. And these are the books that we're going to be talking about today. And we're going to start with the 7 Steps to Managing Your Memory book. And we're going to go through all of these different steps. But the way I'd like to start my talks is by reading a little bit from some of the memory scenarios that we introduce in the preface of the book to get a sense as to what you already know about memory. So what I would like to do, I would like to read through some of these common memory scenarios. And as I read through each one, if you say to yourself, well, that's just normal. That's just what happens to the memory when someone gets a little bit older. If that happens, what I would like you to do is to type a Y into the chat like I've just done. Now, if on the other hand, I read off one of these scenarios and you say, wait a minute, that's not normal. That could be the start of Alzheimer's disease or dementia. If that happens, I want you to type an N into the chat so that you'll tell me that, no, I don't think that is normal. Get it? Okay, so here we go. So here is the first scenario. So you walk into a room to get something and you forget why you're there. What do you think? Is that normal? Yes, a Y, or not normal, and a no? So I'm beginning to get some Ys popping up in the chat. I would like to see a Y from everyone. That one is normal. Woo, thank God, right? That would be a big problem if that one wasn't normal. All right, here is the next one. You have difficulty remembering some of the details of your life, such as your wedding. What do you think? Is that one normal, Y, or not normal? N or no? And all of you who are there in the room, feel free to just shout it out. You can shout out the answers. Very good. Okay, I'm getting a lot of N's there for that one. How about this scenario? When you are driving and not paying attention, you take one or more wrong turns and you end up somewhere you did not intend to be. What do you think? Is that normal? Why? Or shout out yes if you're in the room. or not normal, N, or shout out no. Getting a mixed decision there. Some people say Y, some people say N. How about this one? You have difficulty finding your car in a parking lot. What do you think of that? I'm getting a lot of quick Ys for that one. I think most people are like, I hope that one's normal, right? And my all-time favorite, your family tells you that you've asked that question before. What do you think? Is that normal or not normal? Getting a split decision there on that one too. Some people say yes, some people say no. Well, it is my job this afternoon to empower you all with the knowledge so that you will know whether these and other common memory problems that you may be experiencing or you may see in a loved one, whether these things are normal, whether they're not, and most importantly, what to do about them. And we are going to now dive in to the 7 steps to managing your memory and start with step 1, which is learn what is normal memory. So let's say there's a piece of information that you're trying to remember, like somebody's name. Well, in order to remember that information, I'm going to give you a filing system analogy to show you how it works. And the first part of the filing system I want to introduce to you is the File Clerk. Now, your File Clerk is actually a part of your brain. It's your frontal lobes right behind your forehead. And it's the frontal lobe File Clerk's job to take information in from the outside world and then to put it into the file cabinet. Now, when you want to retrieve a memory, your frontal lobe File Clerk walks over to the file cabinet, looks for the right cubby, finds the information you need, and pulls it out. Well, that's good, but guess what? As we all get older, our frontal lobe File Clerk is getting older too. And I'm going to continue giving you an analogy as to what happens to our older frontal lobe File Clerk as part of normal aging. Well, one thing that happens is our older frontal lobe File Clerk cannot hear quite as well as they used to. What? And because of that, as part of normal aging, information may need to be repeated a couple of times in order for it to get into the file cabinet and we can get a hold of it, okay? So it may need to be repeated for the File Clerk to get a hold of it and put it into the file cabinet. Now, another thing that happens to our older frontal lobe File Clerk is they do not move quite as quickly as they used to. And because of that, as part of normal aging, it may take a little bit of time for the File Clerk to walk over to the file cabinet and get the information that they are looking for. So it may take a little bit longer to retrieve information. Now, the third thing that happens to our older frontal lobe File Clerk is they do not see quite as well as they used to. So you can imagine that as they're sort of squinting at the file cabinet, looking up and down, they may need a hint or a cue to find the information that they are looking for. But importantly, in normal aging, as long as the information has made it into the file cabinet, it should be able to be retrieved, even if it takes a little bit of time or a hint or a cue. So in a nutshell, those are the changes that we expect to see as part of normal aging. Now, in step 2, we talk about the changes that occur in Alzheimer's disease. And we're going to continue with our filing system analogy, but this time we're going to focus on the file cabinet. Now, the file cabinet is another part of your brain. It's called your hippocampus, which is deep in your temporal lobes. So it's right by your temples. If you put your fingers on your temples, it's just deep in there. And the problem in Alzheimer's disease is that Alzheimer's ends up damaging and ultimately destroying the hippocampus, destroying the file cabinet. So the way I think about it, it's as if there's a big hole in the bottom of the file cabinet. Well, if there's a hole in the bottom of the file cabinet, you can have the best, most efficient file clerk in the world, pulling information in from the outside world, putting it into the file cabinet. But what's going to happen? It's going to disappear into the hole, never to be retrieved again. And when that happens, even when information is repeated, even if you wait a bit of time or give a hint or a cue, it cannot be retrieved. And when that happens, we call it rapid forgetting. And rapid forgetting is never normal. It should always be evaluated. Okay, let's talk about some of the other problems that can occur in Alzheimer's disease. And I'm going to stop sharing my slides, and we're just going to talk about some of these problems. So one problem that can happen is in Alzheimer's is that people can get lost. But getting lost is also very common, right? You make a wrong turn, something doesn't look familiar, bam, you're lost. But what do we all normally do? Well, you can pull out a map from your glove compartment, or maybe this day and age, more likely from your phone. You can use a GPS device, or you can pull over and ask for directions. And using any of those methods, you're back on your way. But the problem in Alzheimer's is that paper maps and phone apps and GPS devices can be complicated and confusing to use. You can pull over and ask for directions, but they're often long and detailed and hard to remember. And it's for all those reasons that people with Alzheimer's have trouble getting lost. Let's talk about another problem that happens in Alzheimer's disease, which is losing things, misplacing things. But you know what? Misplacing things is also pretty common. I want you to either raise your hand if you're in the room or have your camera on, or type a Y in the chat if in the last year you have misplaced your keys, glasses, wallet, pocketbook, cell phone. Has that happened to anybody? Yes, no, yes, right. Yeah, you know what? Me too. So if you're losing things, if you're misplacing things, how do you know if it's normal or not? Well, look, if you're someone who every morning, all your life, you spend 5, 10, 15 minutes, hunting around the house looking for things, and now you're getting a little bit older, and you're still spending 5, 10, 15 minutes hunting around the house looking for things, well, guess what? That's probably normal for you and not something to worry about. But if you were someone who was always very organized, always knew where everything was, you never had to hunt around looking for anything, and now it's taking you not only 5, 10, 15 minutes, but maybe more like 20 minutes or an hour, well, that could be a problem. So the point I'm trying to make here is it's not only what the problem is, but it's also whether it represents a change from the way things used to be. Now, the last thing that I want to talk about in this section is about repeating questions and stories. Now, anybody can be halfway through telling a story to a close friend, and you say to yourself, oh my God, I told you this already, didn't I? And anybody can forget the answer to a question and ask it again. But when there is a pattern of repeatedly telling the same story to the same people over and over and over again, or asking the same question to the same people again and again and again, that is not normal. That is usually due to that rapid forgetting that we were talking about. And as I mentioned, rapid forgetting is never normal. It should always be evaluated. Okay, so let's take a look at a few more slides here. We just covered those things. And we're going to move on to step 3, which is understand your memory loss. And I'm going to talk about the question that I get asked more than any other, which is, what's the difference between dementia and Alzheimer's disease? And it's very straightforward. So dementia is a general term that simply means there has been a decline in thinking and memory that is severe enough that it interferes with day-to-day function. And so the way I think about this general term dementia is like I think about another general term like a headache. Now, a headache can be due to a lot of different things. You could have a muscle tension headache or a migraine headache, neither of which are very serious. But you could also have a headache from a stroke or a brain tumor, which obviously are very serious. And with dementia, it's the same way. Believe it or not, one can develop dementia from something as simple and as treatable as a vitamin deficiency or a thyroid disorder. But dementia can also be due to a lot of different brain diseases, including Alzheimer's disease, frontotemporal dementia, dementia with Lewy bodies, which is similar to Parkinson's disease dementia, vascular dementia, which is dementia due to strokes, and there's many other types as well. So dementia is the general category, and Alzheimer's is one type or one kind or one cause of dementia. Let's talk about another term you may have heard of, which is mild cognitive impairment. So mild cognitive impairment is when there's 3 things present. The first is someone is concerned about the memory. It can be the individual themselves, it can be their family, or it can be their doctor. The second is when the individual undergoes pencil and paper testing, yes, indeed, a problem is found. So the concern is confirmed by the pencil and paper testing. The third thing, however, is their day-to-day function is normal. Well, if their day-to-day function is normal, then by definition, they do not have dementia. Now, if you follow people with mild cognitive impairment over time, what you find that approximately half of people do end up declining and developing either Alzheimer's disease or another cause of dementia. But that also means the other half don't. That means the other half either stay stable or their memory actually improves over time. You might say, how does anybody's memory improve over time? Well, one common cause of memory problems is depression, low mood. As their mood lifts and their depression gets better, their memory problems can improve. Another common cause of memory problems are medication side effects. And if the individual works with their doctor and their medications get changed, their memory can improve. Okay. Now we're going to move on to step 4, which is treat your memory loss. But before I tell you about how these medications work, I need to tell you a little bit more about Alzheimer's disease so you'll understand. So we believe that Alzheimer's starts with an accumulation of a protein called beta amyloid. Now, the amyloid clusters and clumps together to form these plaques. The plaques get bigger and bigger and bigger until it starts to damage the neighboring brain cells. And inside the brain cells, another protein called tau gets loose. And the tau is very sticky, and it forms these long chains, and the chains get all tangled up. So these are the plaques and the tangles that you might have heard about with Alzheimer's. Now, once the tangles form inside the cells, it kills the cells. And the cells are normally making chemicals, neurotransmitters, that allow different parts of the brain to talk to one another. And one of these important chemicals is acetylcholine. So in Alzheimer's disease, the levels of acetylcholine drop. It's for these reasons that the mainstay of therapy for Alzheimer's are medications that help to raise up the levels of acetylcholine. These are medications that I bet many of you have heard of. Some of you may be taking these medications. These are medications like donepezil, whose brand name is Aricept, rivastigmine, whose brand name is Exelon, and galantamine. All of these medications can help to turn the clock back on memory problems. And speaking of turning the clock back, that is the perspective that people can see in terms of what these medications can do for individuals, okay? They can turn the clock back by 6 to 12 months. And what I mean by that is when someone comes into my office and I prescribe one of these medications, I can make their memory like it was 6 months ago, or maybe even a full year ago. And the earlier they come to see me, the more likely it is that I'm going to get that full 12 months of turning the clock back. And there's a very simple reason why. There are more likely to be more brain cells that are still living that the medication can work on. So the earlier people come to see me and get on these medications, the better they work. Now, we talked about turning the clock back, but unfortunately, I cannot stop the clock from ticking down. So what that means is that when I see somebody back in 2 years, 3 years, 4 years, yes, it's true, their memory will be worse than when I saw them initially. But that does not mean that the medication is not still working. As long as the medication had a good effect initially, it almost certainly is still working. And because of that, I want people to continue taking it, even if they see things getting worse, because the medicine is still working. So we really want people to take these medications forever. So somebody asked in the chat, what about normal aging? So the medicines don't help in normal aging because acetylcholine levels are normal in normal aging. So it only helps in Alzheimer's and related diseases, including dementia with Lewy bodies and vascular dementia. There was a question about hereditary, and we will talk about that at the end, I promise. Okay, so what about a medication that could actually slow down that ticking clock? And there are medications that are being developed in clinical trials to do just that. Most of the medicines that are being developed in those trials work by either removing the plaques or the tangles in the brain using a variety of different methods. The method that is used most is to create an antibody which is directed against one of those compounds. And antibodies are what your body normally makes to fight against infections, but these are specifically antibodies designed to remove the plaques or the tangles from the brain. Now, some of you may have heard of on the news that there was a new drug developed by the company Biogen called aducanumab or Aduhelm that is supposed to do that. And the FDA actually approved it. But guess what? The FDA's advisory panel did not believe it worked. The FDA's own statisticians did not believe it worked. And I don't believe it works either. So we're still going to have to wait for a new drug to be developed. Now, speaking of medicines that don't work, there's some other things that don't work too. Many people have seen the ads on TV for Prevagen. Unfortunately, save your money. It doesn't work. Curcumin is part of the spice that's used in curry of turmeric. Unfortunately, I'm not convinced with that evidence either, nor with ginkgo biloba, nor with resveratrol, or these other things on these slides. So none of these sort of herbals or supplements work, unfortunately. Okay, well, what are some things that actually do work? Well, in addition to the cholinesterase inhibitors, the medications like donepezil, Aricept, there are some things that you can do. And one of them is to eat a Mediterranean menu of foods. So the Mediterranean menu of foods includes fish, olive oil, avocados, fruits and vegetables, nuts and beans, and whole grains. And from a neighboring diet called the Mind diet, we pull in poultry like chicken and turkey. So these are the things that are good for you to eat. So what are the things that are not good to eat? Well, I hate to tell you, it's almost everything else. So red meats, fried foods, fast foods, butter and margarine, pastries and most sweets, white bread, white flour, white rice, sugar, sodas and juices, as well as diet sodas and juices. Those I would put in the once in a while category, not every single day category. Now, before everybody gets really depressed and thinks, oh my God, I can never have dessert again, I did want to remind you that chocolate in small amounts has been shown to benefit thinking and memory and mood. You just have to remember that it's what type of chocolate? That's right, dark chocolate. The darker, the better, because it's the cocoa that's good for you, not so much the sugar and the butter and the milk they put in it to make it sweet and creamy. Well, now we're going to talk about exercise. And I know that everybody here knows exercise is good for you, but I bet you that I will be able to tell you at least one new thing that you did not know coming in here today about just how good exercise is for you and why. But if I inspire you today, before you lace up your jogging shoes and run out the door saying, I don't care how cold it is, I'm going to go for a run today, I do want you to first check with your doctor and just make sure that your heart and your lungs and your bones and your joints are ready for whatever increased exercise you're going to do. Having said that, there are so many different types of exercise that you can do. I'm sure you can work with your doctor and find some exercise that's healthy for you. And most of the studies that have been done that I'm going to be talking about simply used brisk walking. So brisk walking is a wonderful exercise. Well, the recommendations are that you do at least, note that I'm saying at least 30 minutes a day, 5 days a week of aerobic exercise. You might say, well, what's aerobic? So aerobic is exercise gets your heart beating quickly, gets you breathing heavily. That's how you know it's aerobic. In addition, we also recommend 2 hours a week of exercise that helps with strength and balance and flexibility. So these are things like yoga, Tai Chi, Pilates, and isometric weightlifting. Well, what are the benefits of exercise? Well, everyone knows that exercise reduces your risk of heart disease and strokes, but it's worth mentioning because strokes are a major cause of memory problems. Exercise also reduces falls, and people falling and hitting their head is another major cause of memory problems. We talked earlier about how depression can be a cause of memory problems. And it turns out that exercise is actually a great natural antidepressant. In fact, it's better than many antidepressants that are currently on the market today. Did you know that exercise improves sleep? You might say, well, that's good, but what does sleep have to do with memory? Turns out sleep has a lot to do with memory, and I'll tell you some of the reasons. The first is what I think of as sort of the obvious one, which is that if you're tired because you didn't get good sleep, it's hard to pay attention. And if you don't pay attention, you're not going to remember things. The second reason is it turns out we all make a little bit of this beta amyloid protein during the day, but we normally really literally flush it out of our brains while we are sleeping. The third reason is that a good night's rest helps us to keep our memories for a lifetime. Now, we talked about the hippocampus as the place in the brain where all the new memories are formed and initially stored. But it turns out there's other regions of the brain called the cortex where all the older memories go. And this transfer process from the new memories going to the older memories actually takes place while we are sleeping. So we need to get a good night's rest to hold on to our memories forever. But the most exciting thing that I want to tell you about exercise and memory is that exercise actually releases growth factors from the brain that help us to grow new brain cells. And guess where there are more new brain cells grown than anywhere else? Yes, you guessed it, and you can see it on the slide. It's in the hippocampus. And even in older adults who do regular exercise, in as little as 6 months, you can see how the size of the hippocampus actually increases from these growth factors being released. So people sometimes ask me, Dr. Budson, is there some magic bullet out there that can help my memory? I say, yes, there is. Exercise truly is the magic bullet. Okay, I know there's questions coming in the chat. I promise I will answer them all at the end. Okay, so there are, we're now going to go to step 6, which is strengthen your memory. And everybody always asks me, like, Dr. Budson, what about those computerized brain training games or doing crossword puzzles or Sudoku? Can that help my brain? And the answer is, if you do crossword puzzles or Sudoku or brain training games, you will get better at crossword puzzles and Sudoku and brain training games. It simply does not translate to overall brain function. But there are some things that do. And one of them is participating in social activities. And I know it's been hard with the pandemic, but we're all doing it here today, whether we're doing it in person, wearing masks, or we're doing it over the Zoom, we're participating in social activities. The data also suggests that if you're going to do something with your mind, with your brain, it should be new, should be novel, should be different, and it should stretch yourself, should challenge yourself. So for example, people sometimes ask me, like, I play a musical instrument, does that count? And what I answer is it counts if, in addition to playing the same tunes you've played for a long time, you also learn new tunes, or maybe a whole new genre of music to really challenge yourself. Another thing that has been shown in study after study is that keeping a positive mental attitude is really important. And I know it sounds like pop psychology, but it's really true. And we think it works for all the obvious reasons. People with a positive attitude are more likely to take care of themselves and eat right and exercise. People with a positive attitude are more likely to be social and outgoing. Okay, what about all those brain training games that they advertise? Well, there's new ones coming out every day. There's new studies that are being done. And I'm actually hopeful that one of them or several will be shown to be beneficial in the future. But so far, although I'm sure it's better than TV, there's no evidence that they're helpful right now. Okay. Another thing that we have written into the 7 Steps book are all sorts of different memory strategies that you can use. We have strategies to remember people's names, strategies to remember the names, whether it's a new person you've met or whether you're trying to recall a name of someone you've known for 30 years. We have strategies to help you pay attention, strategies to help you remember your grocery list or your calendar or whatever it is you're trying to remember. We also talk about a lot of different memory aids that can be helpful. Pillbox, to-do lists, notebooks, using your smartphone, putting things in a place, all sorts of different memory aids, physical things that can be helpful. And the last step in this book is about how do you plan your future, okay? So if you have some memory problems, how do you continue doing all the things you enjoy in life? How do you keep working if you're working? How do you keep driving? How do you keep doing your hobbies? And how do you do all these things safely? We also talk about how do you know when is it time to retire from that job? How do you know when is it time to hang up the keys and let someone else do the driving? So those are the 7 steps to managing your memory. And now we're going to transition to the 6 steps to managing Alzheimer's disease and dementia. And this part of the talk is for individuals who are caregivers to a loved one. And I'm again going to read from the preface. And if the things that I'm reading from the preface resonate with you, if you know what we're talking about here, feel free to put a Y in the chat, or if you're in the room, feel free to raise your hand if some of these points resonate. So these are quotes from family members. I always thought I had a lot of patience, but if he asks me what we are doing today one more time, I think I will scream. He wants to drive, but I don't know if it's safe. It's happening every evening now. She keeps saying that she needs to go home, but we're already home. Yesterday, when I came home from the hairdresser, he asked me who I was. He really didn't recognize me. So I see some of these things resonate with some of you. So we're going to talk now about all sorts of things that you caregivers can do. Well, the first step here is about understanding dementia that we've already talked about. The second step is really the bulk of this book, and we talk about how to manage all sorts of different problems without using medications. And we begin with some general approaches, and I'm going to teach you one of these approaches right now, which we call the 4 R's. So when there's a situation where someone's upset, let's say that your loved one is trying to leave the house, they're rattling the door, they're trying to say, I need to go home, and they're rattling the door, they're trying to get out. So you want to begin with the first R, which is reassure. You want to reassure them that everything's okay. The second R is reconsider. We want to reconsider things from their point of view, right? From their point of view, they don't remember that where they are now is their home. They may be remembering a home from their childhood, and that's the home they're trying to go back to. So from their perspective, it makes perfect sense they're trying to go home. The third R is redirect, and we want to direct them to another activity that is both calming and distracting, so they won't be fixated on whatever they were fixated on before. And the fourth R is for all of us caregivers to take in a deep breath and relax, because we need to make sure that our words and our tone of voice and our body language and our gestures, all of those things are calm, because we don't want to inadvertently escalate the situation, even if we're feeling frustrated or angry or irritated, that whatever it is happening for the 100th time. So those are some general steps, and we have other general steps as well. We teach people how to start with small steps, and sometimes we talk about how to really dive into analyzing a behavior in great detail. We talk about not only paying attention to the behavior and quantifying it, not only paying attention to the antecedents, what came before the behavior, but also the consequences, how sometimes how we as caregivers respond to a situation can end up inadvertently making things worse or reinforcing a behavior. So we talk about how you can break behaviors down with these ABCs of antecedents, behaviors, and consequences. After general strategies, we talk about all sorts of different strategies to treat different types of problems, how to treat different types of memory problems, including, if people are forgetting to turn the stove off, how you can unplug the stove or take the knobs off. We talk about how if somebody's wandering, what can you do to both prevent it, but also if it occurs, how you can make a plan for it ahead of time. So when it happens, if it unfortunately happens, you'll at least be ready for it. We talk about what to do about false memories. And in a word, if your loved one says they were just talking with their parents, but their parents have been dead for 30 years, just go with it. Say, oh, that's nice. And then redirect them to a more reality-based conversation. We talk about how to manage language problems, because people not only have trouble finding words with dementia, but also trouble understanding. We want you to do common sense things like check hearing. Don't forget that if language is breaking down, using pictures will often work, as will nonverbal and emotional communication. So you can often still communicate with your loved one, but perhaps not with words. Vision problems are very common. I had an individual in my office yesterday who was having trouble seeing. And although she had eye problems, her ophthalmologist said, your vision problems cannot be explained by your eye problems. And it was because of brain problems from the Alzheimer's disease. They may have trouble recognizing family members. They may think that children are siblings. They may think that spouses are parents. They may sometimes think that you're an imposter. Someone's replaced you. There's all sorts of different vision problems that come up in dementia. We talk about how to deal with all these different problems. We always want to do the obvious things, check the vision and the glasses, make sure that they're good. And a lot of things can be improved by just increasing lighting and contrast. We want to reduce the impact of hallucinations as much as possible. Often hallucinations cannot be completely eliminated, but the idea is to not make them bothersome. Well, we always want to look and treat for depression and anxiety. And sometimes things can look like depression and anxiety, but they're not. And we talk about those situations as well. Managing driving, oh my God, such a problem in dementias. And my solution for this is to have family members sit in the passenger seat of the car when the individual is driving on whatever their normal routes are. If the family members feel very comfortable that the person is a safe driver, then I'm comfortable with them driving. And note that being a safe driver is different than getting lost. I don't really care if somebody gets lost. It's not really a safety issue in the same way, but I do care that they're a safe driver. Okay. There are all sorts of different behavioral issues. Sometimes a behavior problem is from a medical issue, such as a urinary tract infection. So we should always be on the lookout for those. Guns, power tools, knives, all sorts of things like that are important to pay attention to, try to remove or lock up power tools and guns. Sundowning is something that comes up very commonly in dementia. It's when people do poorly in the late afternoon or the evening or nighttime, there's often more trouble with behaviors. And my main advice here is plan around it. You know, if you want to have a family event and include your loved one, don't do it at a time they're not going to be at their best. Do it in the morning or do it in the middle of the day when your loved one will be better. Jealousy and paranoia, very common. It can happen just simply because they don't remember things. Okay, you say, well, where was I? Well, I told you I went to the store. And they say, you didn't tell me you went to the store. You were going to the store. And of course, they don't remember that you said you were going to the store. So it can be just from memory problems, but there's also changes in the brain that can make jealousy and paranoia be more common. My advice is don't argue with it. Use the 4 R's. Sometimes music can be very helpful, as can real pets, robot pets, and even stuffed animals be helpful. Sleep problems are very common. It's important to start with a sleep log. I would say the number one reason that individuals with dementia are thought to have sleep problems is that people think they should be sleeping more than 8 hours a night. So I had one family member, a different patient yesterday, where the family said, doc, you got to give a sleeping medicine for my father. He's up at 4 a.m, waking everybody up. And I say, well, what time did you have him go to bed? Well, he goes to bed at 8 o'clock. So if he goes to bed at 8 o'clock, by 4 a.m., he's had 8 hours sleep. He simply had enough sleep. There's nothing more complicated than that. If you want him to sleep till 7, he needs to go to bed at 11, not at 8. It's as simple as that. A lot of ways to improve sleep habits. There are medical disorders, all sorts of things we can do to help sleep. And then falls are very common. There's a lot of different ways that we can prevent falls, improve walking. You can reduce incontinence with toileting schedules and other types of things. There's advice we can give for tremors, all sorts of different ways to help with bodily functions. Okay, then after all sorts of non-pharmacological ways to manage problems, we talk about how medications are important to look at. And the first thing is there's all sorts of medications that make things worse. And one of the things that I love is that our editor let us put in page after page after page of names of medicines. We have generic names and brand names in about 20 pages. So the idea is you can sort of flip through it and you can see whether your loved one is on any medications that can actually make their thinking and memory worse. Now, that doesn't mean you should stop them, but it does mean you should at least have a discussion with the doctor about whether they need to be on that medicine, or maybe the dose could be lowered or something like that. And then in addition, we talk about ways to introduce medications that could help. So things like donepezil, which can actually help with behaviors. And then there's also medicines to help make people more calm, including the SSRI medicines. That's the Prozac family of medicines. My personal favorites are sertraline, brand name Zoloft, or escitalopram, brand name Lexapro. There's other things that can also be helpful. And then finally, sometimes we need to suppress behaviors, but I always try these sort of more gentle medications first. We talk about how to build your care team, starting with you, the most important member of the care team, how you can care for yourself, okay, because you can't pour from an empty cup. So we want to make sure all your caregivers out there, you exercise, you sleep well, eat a healthy diet, have time to yourself, see your friends. Those are all very important. And then we talk about how do you engage family and friends and neighbors to help you out with all sorts of different tasks, the benefit of support groups, professional caregivers, respite care, day programs, the Alzheimer's Association, and the doctor can all be helpful. In step 5, we talk about why it's important to sustain your relationship with your loved one in dementia, because it really is important, even though it has to change almost always. But it's important to sustain that relationship. And we talk about some specific examples of things that you can do with your loved one that may be one way that you can continue having a good relationship with them. And then finally, we talk about how do you plan for the future. We talk about when to consider, this planning process. The earlier you start, the more likely it is you can involve your loved one in the decision process. Of course, we want to think about medical legal issues and financial legal issues. We want to protect our loved ones from scams and con artists that happen all too commonly. Talk about when do you make a move to assisted living or retirement community or nursing home. Talk about how do you do that? What do you do if they refuse to plan? And then we talk about things like the death itself, the funeral ceremony, the body, all sorts of things like that. And most importantly, how do you plan for your own health and your own future? So those are the 6 steps to managing Alzheimer's disease and dementia. And if you're looking for more information, I have a textbook over here. If any of you are clinicians and want a guide for healthcare professionals, I have a couple of blogs, one for Psychology Today and one for Harvard Health. I don't mind if people email me, and you can also follow me on Twitter and on Facebook. So I'm going to stop sharing my screen, and I'm going to start by answering questions that have been typed into the chat. You can feel free to please type in more questions from the chat, and then I'm happy after we do the chat questions for people to unmute themselves and can ask questions as well. And I know we have a lot of people on Lindsay's computer that may want to ask questions as well. So the first question that I see in the chat is, what is the family or genetic risk of Alzheimer's disease? So there is an increased risk by about 2-fold to 4-fold if one has a family member with the disease. So to put some numbers on this, if the risk of Alzheimer's disease, if you're 65 years or older, is about 3%, with a family history that's doubled to quadrupled. So it becomes 6% to 12%. So on the one hand, it's a big increase in risk. On the other hand, you still have an 88% chance of not having Alzheimer's disease, right? The other way to think about this is that about half of the people who have Alzheimer's disease today have a family history of it, but the other half do not. So really, everyone is at risk. So just because you do have a family history does not mean you're necessarily going to get it. But just because you don't have a family history does not mean that you can avoid it and you don't need to worry about it. So everyone is at risk. Question came up, how do you define a little bit of chocolate? So I think I use small amounts. So a small amount of chocolate, and again, this is from the published studies, is if you think of like one of those Ghirardelli squares, or if you break up a Lindt chocolate bar, one of those squares, it's about 2 Hershey's Kisses. That's the size. I think it's about an ounce of chocolate. And the next question is, does the quality of sleep matter? If I get 6 hours, or if it's broken, second sleep, a nap during the day, is that okay? And the first thing is, there's nothing wrong with taking a nap. Nap is fine. You just have to remember that if you nap during the day, you may not be as tired at night because you may not need as much sleep at night. So, if on average, people need about 8 hours of sleep, or many people need 8 hours of sleep, you may only be able to sleep 7 hours at night if you're sleeping an hour during the day. Now, this person who wrote in said, she gets about 6 hours. Is that okay? Studies have shown that if you're feeling rested and ready to get up and go for your day with 6 hours, that's fine. Less than 6 hours is felt to be too little, but 6 hours to about 8 hours, maybe 8.5 hours, looks like it's just fine. Everyone's a little different on how much sleep they need, and it can differ, from one day to the next or 1 month to the next, how much sleep you need. Okay, there's a question about, is the presentation available for viewing in the future? The answer is yes. Lindsay is recording it, and she will tell us at the end how you can have access to it. Yes, and that was also, yes, and Lindsay typed that into the chat. So here is a question. My mother repeats herself over and over, even when I try and change the conversation, so she can get rid of that train of thought. It's like a record stuck in a groove, fairly maddening if I can be honest. Right, that's why you need to use those 4 R's, including the 4th one, right? Relax. Any thoughts on how to get her to respond and get off that one sentence? Well, you want to try to engage her in some other topic. I mean, it depends a little bit on sort of where she is in the dementia process, but I hope, that she might be interested in looking at, for example, some old pictures, or maybe some new pictures, show her pictures of you or the grandchildren, or maybe show her things from her past. Maybe she'd be interested in singing along with an old record. And I mean, of course, it doesn't have to be a record. You can get it on Spotify. You can get almost anything these days. An old show tune maybe she liked, or something like that. It depends a little on her interest. Or maybe she likes animals. Maybe you could bring in a puppy or a cat or a bird or something that she might like that she could interact with. So I encourage you to be creative. I encourage you to invite your friends and families to brainstorm with you things that can distract her and get her interested in other topics. So now I think I'm going to ask Lindsay if there's any questions in the room that people would like to ask or she would like to relay, while other people are either working to unmute themselves on the call so they can ask a question or so they can type more questions into the chat.
So first of all, thank you so much. This has been wonderful. Does anyone in person want to ask a question or have a comment? Oh, Annie.
That mild cognitive that you mentioned, which is the first stage, how long does it stay mild like that?
Did you hear that?
Yes, I did. But I'm going to repeat the question just to make sure everyone could hear it. So the question is, when someone's in mild cognitive impairment, how long does that stage last? So it can be a little bit different from one person to the next, but generally, when I make a diagnosis of mild cognitive impairment, and it turns out they're one of the 50% of people that do end up declining over time. Usually the decline would be between 1 and 3 years. So meaning that their function is normal when I'm making that diagnosis of mild cognitive impairment. And usually within 1 to 3 years, they're beginning to move into the mild dementia stage, which means that their function will be impaired in 1 to 3 years. But don't forget that in mild cognitive impairment, some people, their thinking and memory stays normal or stays the same, not normal, but stays the same, or their memory can actually improve over time. It depends what the mild cognitive impairment is caused from, because although sometimes it's Alzheimer's, it's not always due to Alzheimer's. Other questions?
Thank you. Does anyone else have a question or comment? No? I think we're all set in person. Maybe if anyone wants to unmute from home. I think I have to allow them to unmute from home. Whoops. Let's see. Okay, so I now allowed you to unmute if you'd like to ask a question or comment. No. Let's see. Maybe I have them, I'm sorry, maybe I have them still muted.
Yeah, I think,
There we go.
I think if,
Or maybe raise your hand if you want to speak.
yeah. Shout out, raise your hand if you're having trouble. You can show your camera. We'll try and help you to unmute if someone has a question. Okay, Marilyn, go ahead.
My question is about sleep.
Yes.
Can you hear me?
Yes, I can.
Okay, thank you. I usually get the right amount of sleep, but it's pretty broken up. I end up having to get up and go to the bathroom. Is it okay if I then am able to go right back to sleep again?
Absolutely. And I'm really glad you brought that up, Marilyn, because in fact, it is 100% normal to wake up 2-3 times in the middle of the night while you're sleeping.
Wow.
Maybe you stay in bed, maybe you get up and go to the bathroom, and then you go back to sleep. That's totally normal. So not something to worry about in the least. As long as at the end of the the night and you wake up and you're feeling rested and ready to go for the day, no problem.
Thank you.
Absolutely. I think Diana and then Sharon.
Yes, I have one question. I'm Diana's husband.
I understand.
Okay. Like a lot of times when we're out, like I'll take her out for dinner, and when the person that's waiting on us, she'll ask him how's your granddaughter doing? And then 5 minutes later, she'll ask the same question again. And then sometimes another 15 minutes go by and she'll ask the same question again. Is that normal?
Yeah, so I would say that's probably not normal. It's probably not normal. So I would recommend, I always recommend starting with your primary care doctor and letting them know. And I would even say, if the primary care doctor says, oh, I think that's okay, you say, I don't know, doc, I was speaking, I heard this memory doctor and he said that's not normal. So that's really not normal. So start with the primary care doctor. If you don't feel, that they're really getting you what you need, you could look to see if there's a memory specialist at your community. And I do see patients in two locations. One is at the Boston Center for Memory, which is a freestanding clinic in Newton, Massachusetts, by the Newton-Needham line, right by 128. And if anyone out there is a veteran, I also see patients at the VA Boston healthcare system in the Jamaica Plain campus. But asking the same questions like that, several times, during a 1 hour time period, it should be checked out.
We are going to, we have an appointment with a neurologist.
So I think that's great. So my
Okay.
comment is mainly that some neurologists are good with memory and some not so much. So you'll just have to see if it seems like you're getting the right answers, good treatment. And one of the things that we talk about in this book, in the 7 Steps to Managing Your Memory book, is like, what are the things that the doctor should be doing in the appointment? So you can go through a little checklist and you can make sure the doctor's doing all the right things.
I'm assuming these books are available at bookstores.
Absolutely. And a big supporter of local bookstores. If you have a local bookstore, that's good. They're available in the library too. So you don't necessarily need to purchase them. You can just go to your local library and look them up. And of course, you can get them on Amazon and Barnes and Nobles and stuff like that. But the library, local bookstores, big supporter of both.
Thank you.
Okay, Sharon had a question.
And I apologize, I'm so dark, but it's very bright over there.
Fine. It's fine, Sharon.
I have been worried, about the amount of sleep, because I've read the same sort of results as you were saying, because I don't get anywhere near that amount of sleep. And I had read, it seemed to be a reputable source, but while you were having the talk, I couldn't find it, that said that actually 4.5 to 6.5 hours is the prime amount of sleep you should have for a great brain. Is that that's not new cutting edge information, that's just wrong?
I'm pretty sure that's just wrong. I reviewed this, the literature not very long ago for a blog I wrote on Harvard Health. And one study suggested less than 6 hours is not optimal. Another study said less than 5 hours can actually increase not only the risk of Alzheimer's, but also death.
Yeah, I read all those studies, which
Yeah.
makes me worry since I'm a light sleeper.
Well,
Always have been.
so being a light sleeper is okay. So it turns out stage 1 sleep, which people often don't even realize they're asleep, that still counts. That's still sleep. I think what I would say is, if you're not sleeping as many hours as you think you should, but you're still wake up, you're feeling energetic, you feel refreshed, I don't know that I would worry about it too much. But, if you start with your primary care doctor, and you may want to see a sleep specialist, you may even want to have a sleep study, to just make sure that you're getting enough sleep and you don't have a sleep disorder, because sleep disorders are very common in general, and they're even more common when people get older. So, that would be my recommendation.
Okay, thanks.
There's one question that came in the chat. What about health professionals who work overnight? Well, working in shifts, which many nurses, other healthcare professionals have to do, in addition to other businesses, industries, it can definitely be disruptive for sleep. I spent my time, doing overnight shifts during my training as a neurologist, for sure. It's not really good for your sleep, but as long as you can sort of make up the sleep at other times, I don't think that it is bad for you or a risk factor as long as you make up the sleep and you sleep at other times. If you're frequently in an evening or a night shift, work on just establishing a routine so you sleep for these hours, during the day. It can be quite challenging if your shifts are always changing. But I think if you do the best you can and you catch up on your sleep, it'll be okay. And that also goes for, new parents or caregivers. I mean, there's all sorts of people whose sleep is disrupted. But I think if you work on trying to make up the sleep, within a 24-hour cycle, it'll be okay. Other questions? Teresa, you are unmuted. Did you have a question?
No. No.
Okay. Any other questions? Lindsay, any questions over there?
It looks like just one last one in the chat here. Besides the primary care provider, what type of doctor is best to explore sleep disorders?
Yeah, so there are people who are experts in sleep medicine. Some of them are pulmonologists, lung doctors, because sometimes there can be trouble breathing as part of the problem. Some of them are neurologists like me, and some of them are psychiatrists. So any of those three specialties may do it. So again, I'm a big believer in starting with your primary care doctor and asking for a sleep specialist that's in your area that might be helpful with your problem.
Thank you very much. Everyone here all set? Any other questions or comments? No. Thank you so much, Dr. Budson. This was wonderful. I did record today, so once it's ready, I'll send it to everyone on the registration list. I'll make it available. And we thank you so much for your time and expertise. This was so fascinating. And well, I'll let everyone here give a wave, say thank you.
Thanks, everyone. Thanks for having me, Lindsay. It was my pleasure.
Thank you. Thank you very much. Have a good day,
Okay.
everybody.
Bye-bye.
Thank you very much.